So let's talk about intracellular accumulations. Intracellular accumulations is just telling us of things that are normally inside the cell, right? But they end up becoming too much than they are supposed to be. So some substances can accumulate inside the cell in large amounts and cause problems in the cell and the organ. Intracellular accumulations, they can either accumulate in the cytoplasm, or they can accumulate where? They can also accumulate in the nucleus. So those are the things that can happen. When you are talking about intracellular accumulations, please don't forget that these are things that are normally present inside the cell, but now they are just in high amounts. That's what we call intracellular accumulations. For example, water, lipids, glycogen, carbohydrates, they are present in the cell, but if they become more, we call them intracellular accumulations. They can as well be abnormal substances which are never present inside the cell. For example, they can either be endogenous or exogenous. Endogenous, these are things that are produced by the body. Exogenous, these are produced from the outside of the body. It can also be pigments. Okay, the pigments, these are colored things which can either be endogenous or exogenous. So starting with these normal things that can accumulate in the body, we start with the lipids. All major lipids can end up accumulating in the body, starting with triglycerides. When triglycerides accumulate in the body, that is known as a steatosis, also known as fatty change. Okay, where these lipids are accumulating in the cytoplasm of the cell. So fatty change is abnormal accumulation of triglycerides within the parenchyma of the cells. Remember, each tissue has got the parenchyma and the stroma. Parenchyma is the actual part that does the actual function of that cell. For example, the liver has got hepatocytes at the parenchyma. And so, where can steatosis or fatty change or accumulation of triglycerides happen? It's normally seen in the liver because it's the liver that is involved in the majority of fatty metabolism. But it can also be seen in the heart, in the muscle, in the kidney. Excess accumulation of these triglycerides within the hepatocytes is going to occur when there is an imbalance between the uptake, utilization, secretion of fatty acids by the affected cell. If you form more, you're supposed to break down more. But if there's any disturbance in the utilization, the uptake or secretion, then these guys can accumulate. So what can cause accumulation of these fatty acids, which we call steatosis? Diabetes mellitus is one of the causes. This is one high yield topic that you need to know in nearly all the courses. You need to know it is high yield in pharmacology, the treatment of diabetes. Is also high yield in pathology. Obesity, if someone is, they have got some more weight. And also toxins like alcohol abuse. Other things that can cause accumulation of these lipids can be protein malnutrition, pregnancy, anoxia or starvation, severe anemia. So what is the morphology? If someone has got a fatty change or steatosis, what are you going to see? Gross, like what you can see with your naked eyes. If the case is not too bad, it's mild, you are going to see for example, if we're talking about the liver, because we said that's a majority, right? The majority of fatty changes happen in the liver. The gross appearance can be normal, but in severe cases, the liver can become large, yellow, and greasy. And then for light microscopy, what you are seeing in the microscope, you are going to be able to see a clear vacuole in the cytoplasm, which will be able to displace the nucleus to the periphery. You know that is fat, right? Fatty droplets, they push the nucleus to the periphery. And then occasionally the cells can as well rupture, the fat globules can merge, producing fatty cysts, where you've got these big fat chunks. And you can use a stain, orange red, with Sudan for or oil red stain. Fat does not stain with eosin if you are staining. This is the first topic we did in histology again. So you can see for a liver that has got steatosis, you can see these white components, those are fatty deposits. Cholesterol can as well accumulate in the cells, specifically if it accumulates in the blood vessel. We call that as atherosclerosis. And this condition is bad because imagine if it accumulates in the blood vessels that supply the heart with blood. What do you think is going to happen? coronary heart disease. The heart will not be receiving blood. The heart can die, to fail. Phospholipids can as well accumulate, all right? And then some other pigments that can accumulate in blood, sorry, not in blood, but inside the cell, intracellular accumulations. Pigments just refer to colored substances. So you can have those which are endogenous and those which are exogenous. Endogenous are synthesized in the body. For example, lipofuscin, melanin, bilirubin, hemosiderin. And then exogenous pigments, these are synthesized outside the body. For example, carbon containing compounds. So starting with the endogenous pigments, we have got lipofuscin. Lipofuscin is also known as a wear and tear or the aging pigment. What have I said? Every time you think of L, remember W. How does it relate? So lipofuscin is wear and tear or aging pigment. It is an endogenous substance and it causes no damage to the cells normally. So if you see this lipofuscin, it indicates history of free radical injury and lipid peroxidation. It is a yellow-brown granular intracytoplasmic pigment. It is prominent in the liver, heart of patients who are undergoing aging, in atrophic tissue, and patients with severe malnutrition and cancer cachexia. Cachexia is representing muscle wasting. So if someone has got a cancer, they are going to have muscles which are wasted, like just wasting, muscle wasting, right? So if we see, because you can see what lipofuscin represents, it represents maybe someone has got malnutrition, severe malnutrition, cancer, or aging. So if you see it in a child, it just means that a child has got malnutrition. You can see the lipofuscin, these things being pointed by an arrow. We said these are yellow brown granular intracytoplasmic pigments. This is in a cardiac cell. Melanin is also a non-hemoglobin brown black pigment normally present in the cytoplasm of melanocytes in the skin's pigment. This is a very good guy for us blacks because it protects us from ultraviolet light rays. It's a very good guy, and it comes from tyrosine. Actually, this one, no, if it accumulates, it will prevent us from skin cancer. But if it accumulates very much in large amounts, it can accumulate in large amounts in benign and malignant melanocytic tumors. What we mean by benign, so cancers or tumors can either be benign or malignant. Benign, these are not really cancers. Malignant, these are the actual cancers that can spread to other bad parts of the body. So we'll talk about this. This is a topic, neoplasia. In inflammatory conditions of the skin, what will happen is that melanin, if there's inflammation, it can spread to the underlying dermis, and that's known as post-inflammatory hyperpigmentation of the skin. If you want to stain melanin, you can use Mason Fontana stain. I love the name Mason Fontana. Bilirubin is another pigment, and this guy is a yellowish pigment and is going to come because of the breakdown of hemoglobin. Let me tell you some biochemistry of bilirubin. What you have is a red blood cell. A red blood cell contains hemoglobin inside it. Actually, one red blood cell contains up to like 25, uh, over 25,000, right? Over 25 million hemoglobin molecules. Each hemoglobin is made up of globin and heme. Heme is made up of iron and protoporphyrin 9. That protoporphyrin, if it's broken down, it can be converted into bilirubin, right? So that's why the breakdown of red blood cells, like for example in hemolytic anemias, can lead to jaundice, especially if this is being broken. Okay, it can lead to jaundice. Why? Because there's a release of bilirubin, especially if it's not being conjugated. That's where the appearance of the yellow color can appear in either the skin or the eyes. So high levels of bilirubin is what leads to jaundice. Jaundice, also known as icterus, specifically happening in children. The icterus is actually bad because in children it can go to what we call the basal ganglia, and the basal ganglia is responsible for regulating movements. So it can disturb movements. You can see how bad it is in children, but for adults they can be able to accommodate that. So this jaundice is a yellowish pigmentation of the skin, as we've said, the conjunctiva, the sclera of the eye is that white part of the eye, and the mucous membrane, and that is because of high bilirubin levels. Urine is also going to be dark. It can also cause itching, also associated with diseases like hepatitis, liver cancer, or obstruction to the biliary tract by gallstones. You can see the person is very yellow. Hemosiderin is another intracellular accumulation. It's actually a hemoglobin derived golden brown iron containing pigment. It's golden brown. Why is it brown? Iron is brown. That is why it is also brown. And it's a product of the breakdown of red blood cells by hemolysis. This hemosiderin exists normally in small amounts in tissue, macrophages of the bone marrow, the liver, and the spleen. If hemosiderin starts getting deposited in the Langerhans cells, these are cells of the skin, of the pancreas, it is going to affect the production of insulin. Like if it starts being deposited in the macrophages that are present in the pancreas, it will start causing problems with the production of insulin. And insulin is necessary for taking for taking glucose from the blood into the cells. So if there's a disturbance, it can lead to diabetes. Morphology: this is the iron pigment. It's golden and granular in cytoplasm of macrophages or in cells of the liver, pancreas, heart. It appears blue-black with pear, Parisian blue stain. So in other words, for hemosiderin, the stain that you can use is pear, Parisian blue, and it appears blue-black. But the hemosiderin itself is golden brown in color because of the iron. So you can see the golden color here with H and E stain. But if you use the Prussian blue stain, it is going to appear blue-black. So how does the accumulation of hemosiderin happen? It's mainly in the macrophages. Okay, mainly in the macrophage, the pigment does not cause tissue damage. So if it can accumulate in the entire body, and that will lead to systemic hemosiderosis, or it can be localized to a specific area, maybe where there is a bruise, a common bruise. There's going to be breaking of red blood cells where there is a bruise, right? And so expect this guy to accumulate. Why? Because they are red blood cells being broken down at that area. And then that is hemosiderosis. Please differentiate it from hemochromatosis. This is accumulation of hemosiderin. Hemosiderosis and hemochromatosis. Hemochromatosis is a more extensive accumulation of hemosiderin, often in parenchymal cells in various organs with associated tissue damage, scarring, and organ dysfunction. It can result in liver fibrosis, heart failure, diabetes mellitus, and skin discoloration. What can cause iron to accumulate in the body? Maybe there's too much absorption of iron. Maybe there's impaired use of iron. Hemolytic anemias: when you're breaking down red blood cells, iron can accumulate. Exogenous iron from blood transfusion. Okay, so this Kamat's simple table is representing the different intracellular accumulations, the stains that you use, and also the color. And then the exogenous pigments, those were endogenous. Exogenous, we have got anthracosis. This is a most common pigment and is carbon containing. For exogenous, normally they are carbon containing, guys. Okay, smoking or carbon particles are inhaled and they are going to enter the lungs. Macrophages are going to try to clean them up, but it is going to take long for them to do so. So when we take the lungs, when we get to take a look at the lungs, we are going to see the black spots, and these are carbon pigments in smoking and when someone has been exposed to carbon particles. So this is how you can see the lungs are, and then this is it on microscopy. And then there's also the co-workers pneumoconiosis. It's a lung disease where there's too much carbon. The difference with the previous one, the anthracosis, is that this one is too much carbon. Other exogenous pigments, plambism, where you've got high levels of lead. So a person is going to have gray discoloration of the skin because of the lead. And then Algeria is where I've got excess silver. There's going to be also great discoloration. And then there's also tattooing, which is allergic reaction caused by the tattoo. Because of the ink that is used, the Indian ink. So for all these condition, macrophages is going for the tattooing, macrophages are going to try to engulf the ink but can't digest it. So you find we find macrophages, of course, in the skin, and so they are going to end up with these blue granules of the pigment. Another one, which another thing that can accumulate is known as amyloid. This is supposed to be a high yield topic, just amyloidosis itself. Amyloid is an extracellular deposition of fibrillar amyloid protein. So amyloid protein can be deposited in the kidney, in the liver, in the blood vessels, in the heart, wherever it's deposited. And it's actually associated with a lot of inherited and inflammatory disorders. When there's accumulation and deposition of amyloid, we call that as amyloidosis. Amyloidosis is a disorder where I've got protein misfolding. And amyloid is actually a non-branching fibril of beta-plated sheet. How you diagnose that if someone has got amyloidosis is that we're going to take a biopsy of the organ, for example, the kidney, the rectum, the gingiva, the skin. Biopsy is you basically cutting the part of that organ. Amyloidosis can either be primary or secondary. Primary is associated with multiple myeloma. This is where I've got antibodies being produced, and you have got problems actually in antibodies. You have got antibodies against antibodies. Can you think of that? And then secondary amyloidosis is associated with a lot of inflammatory and autoimmune diseases like osteomyelitis, tuberculosis, rheumatoid arthritis, and such. The last part of this lecture is on abnormal pathologic calcifications. So abnormal pathologic calcifications are basically talking about accumulation of calcium in the body, all right? Where calcium salts are being deposited in two sites, and that's not normal, it's abnormal. For example, you have got two types. You have got dystrophic calcification and metastatic calcification. Look at where they happen. Dystrophic is normally in the blood vessels, heart, in fat necrosis, samoma bodies. These samoma bodies is a very interesting thing. Areas of trauma, and then metastatic calcification is normally in the kidney, in the lungs, in the stomach, right? So you need to know the difference between these two guys. Dystrophic calcification is the position of calcium in dead or dying tissue. Please take note. Just think of the D for dystrophic, for dying, dead or dying tissue. You are depositing calcium there. So when you look at calcium in blood, the calcium is actually normal, and the metabolism of calcium is also normal. This that dystrophic calcification is seen in areas of necrosis or damage. Metastatic calcification is where there's deposition of calcium in normal and healthy tissue, not in dying, but normal tissue. And this is because you have got high levels of calcium in blood. Okay, but the metabolism of calcium is also abnormal. Maybe that's you are forming too much calcium. So metastatic calcification is related to hypercalcemia. So these are the different causes of hypercalcemia, both dystrophic or metastatic. Mucocalcine syndrome, destruction of bone, because bone stores calcium. So if you destroy bone, you are going to release calcium. For example, in multiple myeloma, this is where I've got antibodies against antibodies. Leukemias, these are cancers of the blood, cancers of the bone. Vitamin D intoxication, mild hypercalcemia, renal failure, hyperparathyroidism. Let me just mention something about the parathyroid gland and then I'm done, because this is basically the last thing. The parathyroid gland releases the parathyroid hormone. What happens is that it will release that parathyroid hormone when you have got little calcium in blood. So if you have got hypocalcemia, the parathyroid hormone has got effect on three main organs: the intestines, the kidney, and also is going to go to the bone. If it goes to the kidney, it is going to cause reabsorption of calcium from the urine. Number two, it is going to activate what we call 1-alpha hydroxylase. That converted calcitriol, actually calcidio to calcitriol, or 25 hydroxyl, what do we call it? 1,25, the full name. Okay, the full name has gone, but that is a inactive form of calcium which we call calcidio to calcitriol. Okay, when you when you form the active form of vitamin D, because of the 1 alpha hydroxylase that you activated, what happens is that the calcitriol, which is the active form of vitamin D, is going to go now to the intestines to cause the reabsorption or absorption of calcium from the food that you've eaten. Besides that, parathyroid hormone can go to the bone and work on osteoclasts, actually on osteoblasts. Osteoblasts is supposed to be building bone. But initially, osteoblasts are going to be activated, they will be building bone. But the overall effect of parathyroid hormone is that to cause osteoblasts to release cytokines, which will stimulate osteoclasts. When osteoclasts are stimulated, they are now going to start breaking down bone. When you break down bone, you are going to release calcium. All right, that is what happens in when you have got hypocalcemia. Another effect of parathyroid hormone is that it will go to the kidney again to cause the release of phosphate, because if you have got phosphate in blood, it's going to attach to calcium. When it attaches to calcium, the body will still record that as you have got low calcium, so you don't want phosphate so that you can have free calcium. That's known as phosphaturia, calcium being released in urine. So hyperparathyroidism is going to lead to hypercalcemia because of what I've just described. It increases calcium levels. Okay, so you can see how when calcium accumulates, you can be able to see what we call samoma bodies, which is a type of dystrophic calcification when there's dye in tissue. And here I've got laminated calcium structures. And samoma bodies are going to be very important when you start talking about thyroid cancer, right? Papillary cancer, papillary thyroid cancer. You can see the way they look. That is basically calcium depositing there. So basically, that is it. And this is a comparison between dystrophic calcification and metastatic. In dystrophic, the definition is deposition of calcium salts in dead or degenerated tissue. Metastatic, deposition of calcium salts in normal tissue. And then in dystrophic calcification, calcium metabolism is normal, and then serum calcium is normal. In metastatic, both are not normal. The causes can be necrosis for dystrophic necrosis, infarction, hematomas, dead parasites, odd scars, and such. In metastatic, can be hyperparathyroidism. There's a cancer there, right? Mucalcaline syndrome, hypercalcemia of infancy, pathogenesis, then is initiation and progression, and then there's high pH. So don't worry much about the pathogenesis. But that, my friends, is what we call intracellular